My colleagues, I'd like to introduce our next speaker. Our next speaker is Professor Fabbri, Leonardo Fabbri from University of Ferrara, Italy. Our next speaker is going to speak to us on COPD management, and he is well fitted for this topic. He is the member of the GOLD Guidelines, Global Initiative of Obstructive Airway Diseases. He's the chief editor of the official journals of the European Respiratory Society. He was actually the president of the European Respiratory Society and is the chief editor of many of its journals, such as the European Respiratory Review, the European Respiratory Monograph, the associate editor of the Lancet Respiratory Medicine, and today he will speak to us on the topic of COPD. Professor Fabbri, it's a great privilege and honor to have you.
Professor Alzabi, it's an honor and a great pleasure to be with you once more. It's a long-lasting collaboration and that became a friendship. So it's an interesting appointment, and I'm really delighted to join you this morning. The title that I was assigned was very clinical. That is the management of stable severe COPD. And what I would like to cover in the next 25 minutes are the following topics. Here are my conflicts of interest. This is a comprehensive summary of the, GOLD document. I will focus only on pharmacological treatment and step up and step down treatment, which are the two key points I think to address in this audience. But of course, I refer you to all the other topics that are contained in the GOLD 2021 document that is my reference textbook. I have three key messages that I've been asked to identify. The first is that the initial response pharmacological treatment of a previously undiagnosed patient with suspect stable COPD is based on respiratory symptoms and history of frequent severe exacerbation, not on lung function. And I will focus briefly on the importance of this concept. The second is that if you think about your symptomatic severe COPD patients, at the present time, I think they eventually will all end up on triple combination, and I will show you why and the problem that are associated with that. And the last, that is, a topic that I'm always been interested in, is that COPD is just the pulmonary component of a chronic multi-morbid disease, and that you have to take care of the patient. This will be only a conceptual, but I always like to underline this concept, because whenever you see a COPD patient, you should think about the associated diseases. Again, the reference document is reported in this website and is updated to 2021. It was updated in a conference held in Philadelphia in the middle of November, and you can download it. And also you can see the proceeding of the meeting that was extremely good in identifying the issue to be discussed. Pharmacologic treatment, step up and step down. The diagnosis of COPD, believe it or not, is still based on clinical issues. By contrast, there are three basic principles if you want to use evidence-based medicine. The patient has to be more than 40. has to have chronic respiratory symptom, particularly dyspnea, a cumulative exposure, and let's say 90% probably, at least in the Western world, is a cigarette, but of course you can consider particularly indoor and outdoor pollution. Once you have these two, you suspect that you have COPD, you make a spirometry. And the spirometry gives you the diagnosis. So you know that that is spirometric confirmed COPD. Once you have done that, you have to deal with risk factor, and you have to repeat spirometry because not always is diagnostic at the first time. And then you, based on symptoms, particular and clinical characteristics, you initiate treatment for the first time, and then you have to go through the characterization of the patient, decide which intervention to make, review them, and adjust them at regular basis. Let's say that at the beginning you need probably 1 month, and then 3 monthly, 6 monthly control will be okay. And the outline is most familiar to you. I won't repeat it. It was the former ABCD algorithm that decide you which one are the starting drugs to use in these patients. Then you check the effect of the drug that you decided to do, and depending on the response in terms of symptoms or exacerbation, you obviously are recommended to check the inhaler technique, adherence, non-pharmacological approach. That's something that I will discuss briefly later. Adjust and then start again. Now, this discussion, the algorithm, is based on symptoms and exacerbation. So the severity of the initial as well as the following treatment is based on clinical issue, not on spirometry. And that has to be very clear from the beginning. Now, once you have the patient that had done the first treatment, then you check it, and depending on the response in terms of exacerbation and dyspnea, you decide whether to increase or decrease the treatment according to an appearingly complicated algorithm, but you can simplify by just saying, you know, basically in a respiratory patient with dyspnea and maybe wheezing, you start with SABA at the very beginning, but then if we are discussing with a patient that daily symptomatic and maybe have a history of exacerbation, you want to start with a long-acting bronchodilator or dual bronchodilator or LABA-ICS combination if you have a history of asthma, or even triple if you have a severe patient, for instance, at the end of an admission to the hospital where you have done everything. You have done the diagnosis, the assessment of severity, you have decided that he's a severe patient at risk of exacerbation. Then when you discharge this patient, you may even start directly with the triple. But having said that, you know, when you are particularly at the first step, if you follow the logic of the minimum treatment required to put them and maintain the disease under control, you start from single long-acting bronchodilator, LABA or LAMA, preferably LAMA, or a double bronchodilator or the double LABA-ICS, but almost invariably, by definition, because the patient has a chronic respiratory disease that is resistance to treatment, you won't abolish the symptoms like you have in asthma, but you have a small decrease in symptoms that prompt you to try almost invariably to step up to triple therapy containing ICS that we know have on a long term some side effects that you have to consider. If this is not enough, you have other options, but that's not the topic for today, roflumilast and macrolide. Now, the first step up is the step up from monotherapy, monobronchodilator to dual bronchodilator. Believe it or not, until this paper, the evidence was conflicting. And it was not clear. There was no evidence that dual bronchodilator was superior to tiotropium particularly. This study that was recently published and has been adopted by the guidelines and valued in the guidelines to support the LABA-LAMA combination, compared LABA-LAMA with the single LAMA, that it was umeclidinium, or LABA, that was salmeterol, and in patient not receiving steroid and not receiving, and not at risk of exacerbation, at high risk of exacerbation. And it clearly showed that it was powered on lung function, but the effect on lung function that was obviously superior with the double bronchodilation compared to individual bronchodilation was interestingly associated in the 6-month study in improvement in quality of life and also in not exacerbation, but on worsening of the disease along the 6 months of duration of the study. I refer you to this study because it's interesting and informative. But again, the other point is to move next. If you have done that, or you have done the LABA ICS, there is a lot of evidence that you know from history, you may consider to step to triple combination. And now we have the first triple combination that were published, where the combination including peclometazone as a steroid, formoterol, and glycopyrronium, and in patients, let's say B and D, so symptomatic and with at least one exacerbation, they consistently showed that triple combination was superior to LABA ICS, triple combination, both in a single inhaler and in separate inhaler, was superior to tiotropium alone, and more importantly, triple combination was superior to LABA-LAMA combination. That actually suggested that, in a step up with to triple, you can obtain significant advantages compared to the previous step. These data were confirmed by a very nice, elegant, large 10,000 patient study, the impact study published in the New England, that showed that triple was definitely superior to LABA-LAMA and LABA-ICS and LABA-LAMA. And the other big, large study showing the same effect was the ETHOS study published in the New England in 2020, also showing a superiority of the triple compared to the double combination. In this study, interestingly, they used 2 doses of steroids that were both effective on exacerbation, but there was a discrepancy on the effect on mortality that we show later. As expected, in these studies, almost all but one, the tribute study, there was an excess of pneumonia associated with the combination containing steroids. It's small, but it's significant and it's consistent. budesonide, fluticasone, or beclometasone, all called a small effect. However, if you take, as Lipson did in his study, the size of the adverse event compared to the size of the positive effect on moderate severe exacerbation is actually much different in terms of number, and so that you may consider that is valuable, to take the chance of the risk of pneumonia or of a pneumonia compared to the significant reduction of moderate severe exacerbation. And that is not only my opinion, but is the opinion of the European agency, medicine agency, that concluded that actually the positive effect outweighed the risk. Nonetheless, having said that, when you have completed this cycle and you are on triple combination, and the studies have conducted so far are only to 1 year length, you have to consider whether or not to take out the steroid that you added. We may consider also take out other components, the bronchodilator, but that's not the topic for today. And the European Respiratory Society published a very nice document showing that, in fact, actually suggesting how to do this. And one is if you have asthma, forget it. Steroids must stay there. If you don't have asthma, check eosinophil. If eosinophil are high, keep the steroids. If the eosinophil are low, but you have frequent exacerbation, we don't have real evidence, but consider the benefits of triple in exacerbation also in patients with low level of or lower than 300 level of eosinophil. If you have no frequent exacerbation and blood eosinophil, low blood eosinophil, then definitely you should consider to step down and go back to maybe the LABA-LAMA combination that I showed you before. In this population, Malte and colleagues showed to be effective. Now, but the most striking results of this large triple study, is the effect of mortality. Both combination containing steroid showed an effect compared to the LAMA-LAMA on all-cause mortality. This is the impact mortality study. Originally, they didn't recruit all the vital, didn't collect the vital status also of the patient who left the study along, and eventually they got to 99.6, I believe, of the population, and that confirmed that patients were, the effect on mortality resisted both on and on off. What does that mean? That also including the patients who were not studied in the primary and that had interrupted the treatment, also including those patients' vital status, the effect remained significant. One of the questions is whether previous treatment could influence this response, and I think that the study, the question mark is whether this initial response that you see steeper in the mortality curve is due to withdrawal of the next steroids. To make a long story short, the answer is most likely not, because they did control for that. The ethos confirmed the effect on mortality, but only on the arm, including the high dose, the medium high dose inhaled steroids, 320 budesonide. But it was significant effect, and also the ethos did exactly the same procedure as the impact. They recruited the whole population until the end, and they came up with a confirmed effect, consistent effect on mortality I recommend you to read the letters, the exchange of letters that clarify that is not confounded by the initial withdrawal of steroids, and interestingly, is not likely to be related to the reduction of exacerbation, things that we may discuss later. Finally, the 3 studies, including beclomethasone, in a post-hoc analysis, they were not designed to address mortality, but they also showed a significant decrease of non-respiratory mortality in these patients. So the bottom line of all this story about step down is consider very careful the pros and the cons of going back. If you achieved better results moving from double therapy to triple therapy, keep going unless you have a serious reason not to continue with steroids, like eosinopenia below 100 or recurrent pneumonia, that, or you have side effects like, diabetes or fracture or other things, but that usually occur years and years after treatment. So this is the synthesis of the recommendation. I think that these recommendations are very good, are very clear, and you should focus and read the paper that is online. And but I suggest you to consider caution when you consider the step down. Manage of comorbidities, very shortly, 2 minutes and we're done. And is the patient with COPD are just patients that have COPD and other concomitant diseases. Is your task as internist before than pulmonologist to search for those comorbidities and treat them, because you treat the patient, you don't treat the lung, and there is some evidence that treating comprehensively the patient may indeed produce better results, certainly in terms of quality of life, but also in terms of survival. Non-pharmacologic treatment is classical. Here I refer you to the gold document, smoking cessation, of course, physical activity, vaccination, pneumococcal vaccination, and this year the document added also the pertussis vaccination, and you do that at all stages. This is a do-do. You have to do this kind of activity. Of course, at the time there is a special chapter on COVID. The bottom line is that COPD patients are at no increased risk of contracting COVID. But if they contract it, they are at higher risk of hospitalization and ICU and mortality. So be careful with this. And finally, the management of COPD and chronic respiratory failure is a separate issue that include the rehabilitation, of course, but long-term oxygen therapy, non-invasive ventilation that has been shown suggesting some effect on survival, lung volume reduction surgery, and lung transplantation. So the bottom line is the summary of the topic that I briefly touched upon. The slides are deposited, so you may download it, and the reference also available. And if you have difficulties, just write me a note, and I'll be happy to send you the reference. Professor Al-Zabi, thank you once again, you and all the participants, for the attention. I'll be happy to take any question.
Thank you very much, Professor. That was a wonderful overview on the management of patients with COPD. And if you would allow me, I'd like to maybe summarize some of the points that you mentioned today. You mentioned that it's important we use spirometry to confirm our suspicion of COPD. However, when it comes to the treatment, it's not the spirometry that tell us where and what agents to start for the patient. It's the patient's clinical parameters, such as patient's symptoms and the patient's exacerbation history. And you nicely showed how different combinations impact on both the exacerbation of patients, symptomatology of patients, and quality of life, and reducing, hopefully, the drop in their lung function also. And then you came into the very end to your point of, if you reach a good stable state with your patient, that you may consider withdrawing the third agent sometimes from triple therapy. However, you mentioned that is done usually carefully in the right patient, such as somebody who doesn't seem to be benefiting from the inhaled corticosteroids, such as somebody who has low eosinophil count, less than 100, for example, or somebody who's had complications of high dose steroids, such as fracture. And last but not least, you came into what everybody is talking about, COPD and COVID-19. And you mentioned clearly that unlike other respiratory diseases such as asthma, COPD has been found to be associated with higher risk of hospitalization and mortality if they contract COVID-19 patients. Tell me, Professor, have you noticed that in Italy, COPD patients and COVID-19?
Basically, the message is the same of all the recent review. That if you run PubMed on COPD and COVID-19, the first is the patient with COPD is not at higher risk of contracting COVID. Having said that, they don't show up in the hospitals. You know, like many other chronic diseases, these people have disappeared. We seems not to have any influenza epidemic this year. You know, because I think that the mask and the distance, the social distance, and the self-protection, the shielding of the patient has resulted in a very low incidence, even of exacerbation of COPD. We'll see after the statistics are more reliable. However, having said that, if you have a severe patient, a patient with severe COPD who gets COVID, is at higher risk of being transferred to the intensive care or to or of death. And there was some suspicion that steroids might increase the risk, but so far. And so the bottom line is that the drug we are treating the patient with COPD, but also asthma, may actually increase the risk of severe disease. But so far, we have no significant demonstration of that. Even the paper that was published in the BMJ that actually showed an association of ICU and mortality with high-dose steroids showed that correcting by severity, that was not due to the steroids, but was due to the severity of the disease.
Thank you. And Professor, although we have a session also on COPD mortality at the end of the day, it's also important to get your opinion, please, since you mentioned it. I would like to get the expert opinion. What do you think about mortality benefit in COPD? Until a couple of years ago, nobody was talking about any medicine reducing mortality in those patients. And I see now you have in your slide mentioning mortality. Why is that? What's changing?
Well, basically, the reason, I don't want to exploit the conclusion of my friend Dave Singh. Please say hello to him that he's giving the lecture this afternoon. But I think that there was indirect evidence also from particularly from the TORCH study, that some effect of mortality of steroids was there. But it was, and I'm talking about studies that use mortality as primary outcome. Basically, only two. One is the the torch, and the second is the summit, and both were the first barely negative, the second negative, basically. So I think that that was the reason. The surprise was to mega studies to show a significant effect prospectively, even if mortality was a secondary outcome. Actually it raised the interest on the topic. I think that the FDA refused the indication of steroids to be used to reduce mortality. So we are not there yet. I don't want to leave you with this message. We are not there yet. We don't have.
Sure.
But in patients who require triple with steroid because they are still symptomatic or have exacerbation, keep in mind that you might have an effect on survival, and that so before taking that additional steroid to the combination, think about it. By the way, the proportion of people with those characteristics, symptomatics with high risk of exacerbation, is only 20–30% of the overall population of COPD. So most of COPD do not need triple therapy. They are just enough with LAMA alone or LABA-LAMA. They don't need it, basically, because they don't have exacerbation, they don't have eosinophil, and so on. But for those who have those characteristics, limited to those people, give it and don't take it out, unless you have good reason.
Thank you. Thank you, Professor.